Today we're going to talk about chapters 16 and 17 in the code book, the 2017 guidelines. I'm combining these two chapters because they're not very long if we do them individually. Chapter 16 are those conditions that originate in the perinatal period, and 17 are congenital, or conditions that a baby is born with, malformations, deformations, and chromosomal abnormalities. Some general rules. We'll cover chapter 16 first. For coding and reporting purposes, the perinatal period is defined as before the birth through the 28th day following the birth. The codes in chapter 16 are never used on the mother's chart, and codes from chapter 15, which is your OB chapter, are never permitted on the baby's chart. Chapter 16 codes can be used, however, throughout the life of the patient if the condition is still present. So even though we are saying only for the newborn babies, that condition, if it persists through a lifetime, codes from chapter 16 can be used throughout the life of the patient, as long as they have the condition. That is one of the guidelines. I wanted to make a distinction here about the principal diagnosis for a birth record, or the baby's record, versus the principal diagnosis for the mother's record. Looking at the title of the guideline, 16 is in purple. That is the chapter 16 in the code book. If it were chapter 15, that would be for the mother. So when you're coding the newborn's record, you're going to assign a code from category Z38 as a principal. And those are differentiated by the type of birth, type of delivery, like cesarean or not, and where, hospital, home, or other. A condition from category Z38 is assigned only once, and that is to the newborn at the time of birth. So the baby's transferred to another facility, Z38 is not going to be used at the receiving hospital. It's only used at the hospital when the baby was born, and only for that episode of care. A code from category Z38 used only on the newborn record, not on the mother's record. The mother's record for principal diagnosis is going to have the delivery as something. Either it's going to be an 080 for a normal delivery with no complications whatsoever, or it's going to be another code from chapter 15 indicating what the complications were related to the delivery. We are going to have the outcome of the delivery on the mother's chart, if you recall some of those codes, but that is not going to be the principal diagnosis for the mother's chart. Let me say that again. The baby's chart, the episode where the baby is born, that category Z38 is going to be the principal. On the mother's chart, you are going to code the outcome of delivery, whether it's a single birth, multiples, whatever, but that is not going to be the principal diagnosis for the mother. Here's an example. Newborn is delivered vaginally in rural hospital A and experienced meconium aspiration resulting in pneumonia. Rural hospital A is not equipped to handle the extensive respiratory therapy this baby needs and transfers the patient to Metropolis Hospital B, where the pneumonia resolves and the newborn is eventually discharged home. And I have two columns here. Rural hospital A is on the left, and you see where the Z38 code is the baby was born in this hospital, and the P24.0 is the meconium aspiration with symptoms. And then when we go to Metro Hospital B, which is where the baby was transferred to, we lose the Z38 code, and we are going to keep the aspiration pneumonia. And then the guideline reiterates what we just said. This would be especially important if you're working in a place like Children's Hospital that gets so many transfers from other facilities. This guideline would definitely be used. And here's the use of Chapter 16 codes after the perinatal period. Remember, the perinatal period is from before birth through 28 days. This is a 7-year-old patient with a history of a birth injury that resulted in Erb's palsy, seen for a subscapularis release. I have two notes here. First is to tell you that Erb's palsy is a paralysis of the arm that's caused by injury to these nerves in the arm. Typically happens during a difficult delivery. And then the anatomy note I have is that the subscapularis is one of 4 muscles that make up the rotator cuff. And I've got all the muscles listed there. I want to strongly encourage you, I hope you've been doing this all along, to really be reviewing your anatomy throughout coding. You're learning to code, yes, but you're also reviewing anatomy if you've been a while since you've had that course. It's so important that you know anatomy in order to code accurately. Plus, it makes it a lot more interesting. It's kind of boring to just put numbers on things all the time, but if you know and you can visualize in your mind the condition or the procedure that you're coding, it certainly is a lot more interesting. So this is just a reminder that we can use those Chapter 16 codes after the perinatal period as long as the patient has the condition. And here's another guideline that has to do with conditions that have implications for future health care. The guideline tells us that you can assign codes for conditions that have been specified by the provider as having implications for future health care needs. This guideline would not be used for adult patients. This is only for babies that are born with the condition that the doctor says this might cause this child some problems later on in life. Okay, let's look at the scenario. Here's a note from the medical records of a newborn born during this hospitalization. An abnormal noise was heard in the left hip of a post-term newborn during a physical examination. Post-term is significant and there is a code for that. The pediatrician would like to follow the patient after discharge, as a hip click can be an early sign of hip dysplasia. The newborn was delivered via cesarean at 41 weeks. And I have the codes here. You see the Z38 code is going to be the principal diagnosis. Z38.01 is born in hospital by cesarean. We are going to make a note of the post-term newborn, P08.21, and then the hip click, or the clicking hip, as the index states it, R29.4, will be coded because the physician stated what he did. If the physician had just said, I heard a left hip clicking, but didn't make any kind of note in his documentation that this might have future implications, you would not code it. But because he made this implication here, and because we have a guideline that tells us to assign codes for conditions that have been specified as having implications for future healthcare needs, you are going to code it. Another reminder of how important it is to read all of the record to be sure that you're coding accurately. This guideline has to do with low birth weight and immaturity status. Here's a patient now 35 years old who weighed 659 grams at birth, quite small, is seen for heart disease documented as being a consequence of a low birth weight. The heart disease as such is extremely unspecific, so it gets an I51.9 code, and then the low birth weight is going to be coded as P07.02, and you see here in our pathway it's an extremely low weight. And the reason why this is coded is because in the guidelines it tells us if a patient, either child or adult, very important to note there, child or adult, was premature or had a low birth weight as a newborn, and this is affecting that patient's current health status, we can pull codes from Chapter 16. You see there's a lot of rules around when we can use Chapter 16 codes, so it's important to remember these guidelines. This guideline has to do with bacterial sepsis of a newborn. Full-term infant develops severe sepsis 24 hours after discharge from the hospital, is readmitted, and cultures identified E. coli as the infective agent. The first thing I want you to notice is that Z38 category is not our principal because the baby was not born during this episode of care. The baby was born 24 hours ago, had been discharged from the hospital and gone home, and is now back in the hospital. So we're not going to use that Z38 code again. That was only for the episode of care when the child was born. We are going to code the sepsis due to E. coli, and you notice that there is a code specific to E. coli sepsis because it's relatively common in the baby, and because it is quoted as a severe sepsis in the documentation, we will code it as such. There is a difference in sepsis and severe sepsis. Those words are significant when you're assigning codes. Our guidelines tell us if the perinate is documented as having sepsis without documentation of congenital or community acquired, the default is congenital. In other words, the baby's coming back to the hospital. The documentation does not tell us if the sepsis was born with it, which would be congenital, or developed in the hospital or in the community, which would be community acquired. The documentation doesn't tell us, so we're going to code this sepsis as congenital, and that puts us in the P36 category. Then I have additional information here. If it had not told us what bacterium or organism was causing the infection, we would want to code that in our B95 or B96 categories. And we would also use additional codes to identify any organ dysfunction if that were listed in our documentation, which it is not. Now let's talk about Chapter 17. These are the congenital malformations, deformations, and chromosomal abnormalities. Congenital always means born with. So a code from Chapter 17 can be the principal, or it can be a secondary. It depends on what is bringing the patient into the hospital. When a malformation, deformation, or a chromosomal abnormality does not have a unique code, we can assign codes for any manifestations that we see that are not inherent to whatever condition we're coding. This is why it's important for us to understand our disease processes, because if you don't know what symptoms are inherent or go along with an illness, then you may very well be coding those signs and symptoms, and maybe you shouldn't. Manifestations, as it states to us here in our guideline, that are inherent or things that you will see with this condition should not be coded. Codes from Chapter 17 can be used throughout the life of the patient. Even though they are congenital codes, there's something a person is born with, you can use them throughout the life of the patient. If that congenital malformation or deformity has been corrected, we can use a personal history code to identify the history of the malformation or deformity, and that way it is on the record and the doctors know that this person did have this condition, but it's been corrected. And there's times when the baby may be born with this problem, but it's not identified until later in life. So whenever it is identified, it's appropriate to assign a code from Chapter 17. As we mentioned before, for the birth admission, the appropriate code from Category Z38 should be the principal, and then any congenital anomaly would be secondary diagnosis. If we follow the guidelines closely, they will almost always tell us how to sequence our codes, but we have to take the time to read them so that we know that. There's only a couple of examples here because there's not very many guidelines. The first one is an 8-day-old infant with tetralogy of Fallot and a pulmonary stenosis. That pulmonary stenosis is inherent in the disease process of the tetralogy of Fallot. So we would not code the pulmonary stenosis. We would only code the condition. If you were working in the hospital and you didn't know what this is, you would look it up. You would go to Google or any search engine you want to use, or your text, some kind of reference book on your desk or in your computer. Go online, look at that condition, and read what the components or the manifestations of that condition are. Make notes, if you will, in a notebook. Especially when you first start coding, it's going to be so important that you remember that you are in learning mode big time when you start coding, to be sure that you're picking up on all of these things. The next guideline has to do with when you might code those manifestations. This particular one, the 7-month-old infant with Down syndrome and common atrioventricular canal. Couple of things I want to make a point of saying. Too often we hear the word Down's syndrome. That is not correct. It is Down, D-O-W-N, without an apostrophe S, Down syndrome. And this is another one of those cases where you need to know that a common AV canal is not inherent to a child born with Down syndrome. So you would code it in this case, and I've assigned the codes here. A 3-year-old with a history of a corrected ventricular septal defect. You see, it's a personal history code, a congenital malformation, and in this case it had to do with the heart. Z87.74. It would be important as that child grows up for the doctors that are caring for him to know that he's got this history of that correction. A 40-year-old man with headaches diagnosed with congenital arteriovenous malformation of the brain by brain scan. You have here the code. This is one of those examples where the man was born with this condition, but it wasn't identified until he was much later in life. No one had looked at a brain scan before he was 40 years old to know that he had this condition. But once it's been diagnosed, we would pull from Chapter 17 because it is a congenital malformation. A newborn with anencephaly delivered vaginally in the hospital. Our Z38 category would be our principal diagnosis, and the anencephalus would be our secondary diagnosis. This is just reminding us that Z38 is going to be the principal, and whatever is wrong, the congenital code, is going to be the secondary. If you have any questions about Chapters 16 and 17's coding guidelines, please post them in the discussion board, and I will try to answer them. And I hope you have a good day.